Hello, I'm Faith Rogers, host of today's program, COVID-19, Keeping Up with the Moving Target. Thank you for joining us. This activity is jointly provided by the Postgraduate Institute for Medicine, DKB Med, and the Institute for Johns Hopkins Nursing. Today's program is accredited for ANCC, AAPA, and AMA-PRA Category 1 credits. Please visit our website for complete CE information. If you're tuning into our webcast, please click the Claim Credit button on the webinar console. Otherwise, please go to covid19.dkbmed.com, navigate to our multi-specialty episodes, and select the webinar to claim credit. Today's learning objective is to discuss new FDA authorization for second booster doses. This educational activity is supported by independent medical educational grants from Gilead Sciences Incorporated, as well as in-kind support from DKB Med. With us today, we have Dr. Paul Auwaerter, the Clinical Director of the Division of Infectious Diseases at Johns Hopkins University School of Medicine. Dr. Auwaerter, thank you so much for your time today.
Yeah, as always, Faith, glad to be here. Two topics for today. One is the Omicron lineage subvariant BA.2, and a bit of a report card there. And the second will be the Food and Drug Administration's decision to authorize additional boosters, which has prompted a lot of questions and always has from patients. What the Centers for Disease Control announced was that this BA.2 subvariant now is a predominant infection, at least in the past week, identified in the United States. And you can see the rapid uptick, which again, this BA.2 variant compared to the original Omicron, BA.1.1.529 or BA.1.1, is rapidly replacing. And because it is more contagious with R naught that's probably north of 8, this likely will again sort of do what Omicron did initially and really replace the Delta variant that you see in orange. Now, this variant so far has not seemed to have increased virulence factors. And indeed, the Omicron family, as it were, has a number of different mutations, some of which overlap and others are independent. And the BA.2 especially had a large number of mutations that were unique. So looking at all those extra mutations, where does BA.2 fall? And Bill Hazeltine, who's a virologist, wrote an article, but had a nice sort of picture that I think sort of captures where we've started with the ancestral strain from Wuhan all the way to now BA.2. And in terms of transmissibility, it has been a relentless march that each major variant, which has really replaced the previous one, have all been even more contagious than the one prior. And I don't see any reason for that stopping. Now, in terms of so-called pathogenicity or virulence, we didn't see much of a change until Delta. And Delta definitely caused more problems than Alpha or the earlier variant and the ancestral strain. Whereas BA.2, much like Omicron, seems to be less than what we saw with Delta. And of course, it's always a little hard to know because we only can look at unimmunized populations, and those numbers are decreasing and still remain one of the major reasons people end up in the hospital is that they're unimmunized or haven't previously had COVID-19. If you're wondering about what's happening in terms of viral evolution, I think this is important as well. But of significance, the NIH has this very handy accumulation of data that's put on an easy to understand graph regarding antibody-based therapies, because obviously those are most affected by changes in the spike protein, which characterizes these different subvariants. So this particular graph, I just toggled on the green, and our recent go-to monoclonal antibody is sotrovimab, which you can see falls between 10 to 100-fold less activity against BA.2, which means it probably still has some activity, but it may not be optimal, and certainly not in the 1,000 club, which is why bamlanivimab, etesivimab, and also casirivimab and divimab fell off when Omicron emerged because of its decided lack of in vitro activity, and the thought this would not have any clinical impact in that case. The other thing I would draw your attention to is that one of the antibodies where you see green dots just centering around one is bebtelovimab, which was recently authorized by the Food and Drug Administration for emergency use, but has very slender clinical data with use as a sole agent. But this monoclonal and monoclonals generally have behaved according to their in vitro activity. So this now in many states where the BA.2 variant is judged to be more than 50%, is thought to be the antibody that should be employed. At Johns Hopkins, we're north of that, although our state, again, is a little more heterogeneous. So whether your state has the numbers sufficient to roll it out, I think does depend on overall state numbers largely. One last item to mention is that the combination of silgivimab and tixagivimab, which is shown as Evusheld in the top row, is the pre-exposure monoclonal antibody combination that lasts for 6 months or more. And this has been rolled out starting in December for patients who are severely immunosuppressed and not thought to respond to well to vaccination, or who can't get a vaccine. And at least with the BA.2 variant, you could see it actually seems to have more activity against this subvariant compared to the other gray dots, which are the other sublineages, which are sort of grayed out on this visualization of the graph. So whereas the original Omicron was concerned that it may not work very well, now that this is becoming dominant, it may give our patients actually more of an impetus to go and get it if it's appropriate for them, and also a bit more confidence that perhaps this monoclonal antibody will protect them more so than the prior Omicron variants. The second part is boosters. Now, people have been asking me about an additional booster since the first ones were authorized last summer. But the Food and Drug Administration has decided yesterday, being March 29th, to authorize a second booster shot for anyone over 50 or those who are significantly immunosuppressed, such as solid organ transplants or those with similar risk levels. Now, this decision, I would say, remains controversial, just as the first booster did. Now, many scientists and public health authorities argued that a booster wasn't needed because 2 shots worked very well against Delta, but then clearly Omicron came about and showed the role that a third dose might benefit, meaning the first booster. So now booster number 2 means that patients are either getting a 4th or a 5th dose, with patients who are relatively healthy but over 50 getting dose number 4, and this should be at least 4 months after dose number 3. For solid organ transplants or those with similar risks of immunosuppression, they would be getting dose number 5, because remember, they get 3 doses as part of their primary series. That first booster dose is 3 months after the primary series of 3 shots. But this one, again, is the second booster here is, again, similar, 4 months after booster number 1. the information about this, of course, the CDC and the Advisory Committee on Immunization Practices haven't yet weighed in. And the risk levels in these groups do differ. I mean, someone who's 80 is different than 50. The number of comorbidities. Did you get a booster shot in August, or did you get it, just 3 months ago? What's going on with the circulating variant, and what are your community rates? So this debate about benefits, I think, is important. Now, much of the data I think that the FDA has relied upon has come from Israel, which has always been at the forefront of using extra doses. And the preliminary data in a letter, and I'm sorry, the references are cut off from here, but there was a letter to the editor in the New England Journal that looked at a fourth dose of what's generally Pfizer a vaccine that appeared safe. And interestingly, that fourth dose, when studied in healthcare workers, did not raise the levels as much as the third dose. And the thought was, at least in healthier people who were healthcare workers, they could still get Omicron and have a very high viral load. So it didn't even really impact on transmission possibilities. So overall, there wasn't a lot of compelling data to recommend a fourth dose from this series. But then a case match control has been available by preprint that had only a 10-week follow-up, but they did show protection for those who are 60 and over against severe COVID in the face of Omicron compared to a third dose. And of course, this was just a case match control, but the peak protection seemed to be for 3 weeks and then waned faster than it did after the third dose data from earlier in the summer, when you perhaps got about 12 weeks of good protection along those lines. So again, if you're thinking about giving or using a fourth booster dose in people that I would say average to increased risk, but not immunosuppressed, you can also question whether, what's the right timing for this? Is it better now and to elect whether, or suspect, I should say, whether a new variant will cause problems? We know the BA.2 subvariant isn't generally worse compared to Omicron, or do you wait until you see a new variant or higher community rates? And personally, I feel that I've decided myself to wait at this time before getting a fourth dose. I would be over 50. I'm 60 right now. I don't have any special risks otherwise. So that's my decision. But I think this could certainly be individualized. But whether to get a fourth dose now or wait is a complicated issue there. And I think there's mixed data about benefits in many of these groups. So Faith, I understand we have a couple of questions.
Thank you very much, and I'll move forward with the first learner question here. For the newly authorized second booster, is there any advantage to using a vaccine that was not part of the primary series or the first booster?
Well, these boosters are all mRNA vaccines, Faith, and there isn't a lot of data about mix and match amongst mRNA vaccines. There has been some data from the primary series that would suggest the higher RNA dose in the Moderna vaccine engenders somewhat higher and longer lasting antibody titers. But I haven't seen anything here that would suggest you should seek one or the other. I've stuck with just getting the Pfizer, the devil you know, as it were. But for people that may have gotten J&J or other vaccines, especially if you were abroad and got the AstraZeneca vaccine, we know from the CombiVac study that getting an mRNA vaccine after these non-mRNA vaccines certainly enhanced your immuno responses. So that would be the way to go there. Absent, though, in this case, was information about people who got J&J. So this may be forthcoming.
Thank you. And finally, The CDC statement on isolation states that people who test positive for COVID-19 should isolate for 5 days. So is 5 days enough considering that many people will still test positive on a rapid antigen for around 10 days?
Yeah, so this is a question which I think, especially with Omicron, we don't really know for sure. The CDC in December elected to shorten first for healthcare workers and then for all the rule to 5 days because many people were not waiting the full 10 days anyway for isolation. Uh, we do know that maybe 15% or so of people might still have infectious virus after 5 days, and a rapid antigen test is not a bad surrogate because you will only detect higher viral load levels. And so not everybody's non-infectious at 5 days, but I'd remind you that the CDC does advise that two things. One is to wear a well-fitting mask once you leave isolation after 5 days to help you avoid transmission if you fall into this not still infectious group. The other is to not be around high risk people if at all possible during those extra 5 days till you get to day 10. Or, um, you may elect to remain isolated, especially if there's someone in the home who might be at high risk for severe COVID until you either test negative or for the full 10 days, assuming you're not immunosuppressed. So I think if you're highly concerned, you could still wait the full 10 days. But this was really a practical measure that I view. And so far, it does not seem to have caused problems because, at least in the United States, even though BA.2 is more contagious, we've not yet seen an upsurge despite the dropping of a lot of mask mandates. So we'll see. BA.2 in Europe had substantial number of cases, for example, in UK, Denmark, and Germany, but hospitals have not been that busy. And I think that's a combination of people who have had infection-acquired immunity, even if they've not been immunized, and of course, people that have been immunized and boosted, such that they're not severely ill. And that's really what counts.
Dr. Auwaerter, thank you so much for those updates. If you're tuning into our webcast, please click the Claim Credit button in the webinar console to attest for credit. Otherwise, please visit us at covid19.dkbmed.com. Again, thank you for joining us and thank you for your dedication to your patients with COVID-19. Thanks again, Dr. Auwaerter.
Well, thank you, Faith. And I'm sure this story will continue some want to evolve, but I truly hope that we don't see any major surges down the road.